Good evening, ladies and gentlemen. Thank you for a nice introduction and inviting me to present some clinical cases from clinical trial to clinic practice. So in next 15 to 20 minutes, I will take you through some cases, how we face challenges and how we solve it by using the different resources and the guideline. So how do you choose frontline treatment for multiple myeloma management? Which guideline you use to treat in hematology? So use first for these. Mostly people use NCCN guidelines. Some people use expert online. So my frontline therapy option in multiple myeloma, who is non-transplant candidate, what are the treatment options as per NCCN 2023? So these are preferred regimen, and there are some other recommendation, and there is some useful certain circumstances. So you have a lot of options. So this create a challenge. How do you choose out of 10 one option? Similarly, patient who is candidate for transplant, you have preferred regimen, you have other regimen, and useful in certain circumstances. Again, you have 20 options. So how do you choose? This bring a challenge. So for multiple myeloma, you have multiple options. So how do we sequence and stratify to ensure the best outcome of the patient? How I treat it? I treat actually by ABC. First, making accurate diagnosis. B, before C, there is indication. They choose the wisely drugs depending on what is your target, and targets are these 5 lines. I make it. First line is standard line below, and then second is yellow, which is above standard, then aggressive line, which is the third one, and fourth is the green one, which is the soft patient, and then flip line, which is poor performance patient. So based on this, I started treatment. Then, but burning question in 2022 is a newly diagnosed patient, should we use all the treatment best option first or keep for later? This will address also in these my cases. So my first case is 62-year female who presented with the shortness of breath to Bridges Hospital in Sharjah, where she was found acute renal failure. She underwent investigation, kidney biopsy, which revealed amyloidosis, and bone marrow also showed involvement of plasma cells. She has background of diabetes and hypertension. She has backache, and there is monolithic lesion. Her performance status is 1 to 2. So bone marrow confirmed she has 30% plasma cells, and she has all the ISS score high profile, beta 2 microglobin about 6, LDH 350, low albumin, and the normal cytogenetics. So she has stage 3 ISS, and before beginning treatment, she has also indication of the treatment. These are the graph of the patient. You can say she has this kappa, which was about 500, and the renal profile, you can say this is the blue line. This is very high creatinine and high LDH count. So she has aggressive disease. Now, if you go by NCCN guideline, again, preferred regimen are RVD, and other regimens are DARA RVD. But as I mentioned, she has very severe renal failure. So physicians wanted to give the treatment, but to avoid lenalidomide. So the other options, there are actually DARA, CVD as well. So the quadruplet was chosen keeping in renal failure circumstances. So she was started actually standard quadruplet, DARA plus cyclophosphamide, Velcade plus dexamethasone, and she received 1 cycle over there, and then she was referred to Tamam Hospital. We also confirmed she on the bone marrow based and kidney biopsy, she has amyloidosis with the multiple myeloma. So we recommended she will continue the treatment, and after 4 cycles, she will go for autologous transplant. As mentioned here, even in non-transplant candidates, she can go also DARA CVD-based chemotherapy. However, you can see each cycle we check the kappa chain, and you can see each cycle is going down. After 2 cycles, her kappa was almost normalized, but she didn't go for a transplant. So we continue about 8 cycles of the DARA CVD-based chemotherapy, and now she will go for maintenance DARA Velcade-based chemotherapy. So this is the whole journey of the patient. You can see kappa, this is the yellow color, it go down after 2 cycles, and these are the kidney, you can say this is the blue is still in renal failure, and LDH is going down. So after 8 cycle, the patient has also still nephropathy as well, but her myeloma is almost subsided, so she will go for maintenance therapy. Again, case number 2, 53-year-old male who was seen first in the clinic for normal workup, and he was found weak and tired. CBC was found pancytopenia. That's the reason he was referred to hematology oncology, as we found there is Rolex formation as well. So we requested immunoglobulin and serum protein electrophoresis. That come actually IgA level is very high, 59, and PET scan also revealed there are multiple lesions and plus extramedullary disease in the spine as well. MRI confirmed there is no cord compression. Bone marrow confirmed is multiple myeloma. He has double cytogenetics 414 and IQ amplification. He had history of amyloidosis. He had history of actually clavicular fracture in the July 2022 without any specific trauma. So this was the bone marrow report that revealed 60% plasma cell, and this is the cytogenetics and FISH. They revealed 3 types of abnormal cytogenetics, IQ1 and 414, there was present. So considering his presentation with the pancytopenia and secondary heavy bone infiltration as and he had stage 3 ISS with the double hit FISH abnormality, we consider very high risk multiple myeloma. And young patient, we recommended quadruplet regimen, DARA plus RVD chemotherapy, and followed by autologous transplant. So he was started first cycle, and his pancytopenia actually relieves after first cycle. You can see this was the first cycle, and you can see the only just first cycle of the DARA RVD with chemotherapy, the lambda chain gone from 450 to almost normal. This is the whole journey, and you can see the CBC also recovered and LDH is also going down. So this patient will go after 4 cycle of quadruplet to autologous transplant. Now, two cases which are not candidate for autologous transplant. 78-year male who had history of backache, diabetes, hypertension. He is retired, and this is the pathology of the bone marrow that revealed the plasma cells and the high I score of ISS based on the beta 2 and LDH and albumin and the hyper-diploid cryotype. So he has this one diagnosis. So we have to start the treatment now. As the patient is old, naturally he is not candidate for transplant. So evaluation of the treatment, MP, then Lendex, then RVD. Now we are in era of DARA, Lendex. So what are the treatment option? Now treatment option again, or the triplet, or the doublet, or you can continue by the DARA-based chemotherapy. So if you go by the guideline, and the guidelines say go for DARA, Lendex, International Myeloma group same, and then ESMO group same, and then expert online, they also say DARA, Lendex-based chemotherapy. So in this patient, actually, we choose DARA, RD, Mayer trial-based chemotherapy, and you can say after first cycle, he has partial response and pain-free, and after 4 cycle, she has complete response, and she will continue. Now, similarly, another case, 70-year-old lady, whose performance status is poor, 2 to 3. She has history of ischemic cardiac disease. She was found actually in short multiple myeloma stage 3. The important thing is she had acute kidney injury with severe hypercalcemia, and she was given all the things to control the calcium, calcitonin, denosumab, and finally we started DARA and very low dose of lenalidomide. So this is the humerus fracture of that lady. She has very aggressive disease. So, but with the first cycle, you can see the light chain of the light chain is going down of the, and this is how you can say this one is green is the kappa chain go down, and also IgG from 70 it has gone to almost normal after 2 cycles of the therapy. So this is how the beauty of the DARA Lendex chemotherapy, which works in both cases. Now just bit 5 minutes what we used to do in previously in 2007, suppose this was multiple myeloma case who was diagnosed again the high risk disease, and what we did in this case, you see, first we cyborg protocol, PFS of 2 Then VRD protocol, again, you can say is 1.5 years. Eventually, the patient took now DARA-based chemotherapy, DARA-RD-based chemotherapy. Now he's more than 2 years under DARA-RD-based chemotherapy. So eventually it came back historically as well. So there is another case, 68-year, I call as orange line, means who last to follow up, who received VRD, then lenalidomide, then last to follow up. Then in this patient, actually, we started KD-based chemotherapy, but the problem is the patient has poor compliance, and he wanted to just oral chemotherapy. In this, we started palbociclib oral chemotherapy. Is doing great. And similarly, another patient who was 67-year male and who has high risk of the disease, double hit, and there is too many vertebrae also affected. First, in the initially started radiotherapy, then again VRD, DARA, KD, and finally he is on oral PCD chemotherapy because of poor compliance. He cannot take further chemotherapy. Now, this is ultra high risk patient who young male who has plasma cell leukemia with extramedullary disease. Here you can see VRD, DARA, KD, and he continued with the DARA, KD. You can see 3 years on therapy. He was doing great. And this is again, the DARA-based chemotherapy will continue. And now again, the disease is progressing. Then we have to give something cyclo plus DARA, KD chemotherapy. So all patient does not need, again, the aggressive therapy. I would say some patient on the green line that you have to just this elderly lady who has very low profile of the disease, just on the VD-based chemotherapy over 3.5 years with the renal dysfunction. You can see that beautifully she is maintaining the lambda graph just for simple mono VD-based chemotherapy. So last 15 to 20 minutes, what I emphasize based on the aggressiveness of the disease, you have to choose. If it's green type of the patient, just simple doublet is enough. But if you have from red to blue type of the patients, you have to choose quadruplet, which we use to first patient in transplant patient. First patient, you remember I use DARA CVD-based chemotherapy, and other is DARA RVD-based chemotherapy. And similarly, elderly patient, I use DARA Lendex in 2 patients. And the patient, this is orange, as this is soft line. In this, the patient take just simple oral medication, POMA and cycloplex chemotherapy. So this is my take-home message in the contents of the advanced new multiple myeloma treatment landscape. To present my cases, what I wanted to show you, how we face some challenges and how we solve those challenges based on the clinical trial, and how we use the guideline, and we can use the resources to solve the issues. Thank you very much. If any question I may have with you. Thank you very much.